by the hospital, which is the virtual ward. Who would have thought that a few years back that the world would be changed very much by a pandemic? And it made many of us think about different ways to provide service and alternatives in terms of bed capacity. Just in case you didn't know, Dr. Terence Ong, I'd like to just say a few words. Dr. Terence Ong is a consultant geriatrician and an essential member, a key member of the geriatric medicine team. His primary interest really is very much in bone health, and he literally runs the auto-geriatric liaison service together with Prof. Kor Hui Min. With regards to the virtual ward, he's the lead clinician, and together with matron Norina, sister Nadia, as well as Dr. Amanda Goh, I'd like to invite Dr. Terence to present the virtual ward.
Thank you. Thanks very much, Prof. Chin, and thank you to everyone who's joined us on this wonderful Wednesday morning. So let me get my slides up. Okay, thank you, IT team. All right, so virtual ward and introduction. So this is by no means a lecture about virtual wards, but very much to introduce some key principles of what a virtual ward is, and then bring it back to what we're trying to do within PPUM. So I thought we could very much try and set the scene by very much describing what a virtual ward essentially is. And I've plucked this particular definition from NHS England. So the NHS England, perhaps if we think globally, internationally, perhaps are the biggest investors within virtual ward services. So this is how they describe what a virtual ward is. It's a model of care where we allow patients to get hospital-level care at home safely, in familiar surroundings, with the aim that this would speed up the recovery and freeing up hospital beds for patients that need them most. And when we look at the literature around virtual wards, you will start to see the terms virtual wards and hospital at home being used quite interchangeably. I mean, certainly within this particular NHS document, they said both are very much equally the same. But for the purposes of this part of the presentation, I'm going to refer to this type of models of care as hospital at home, and perhaps later on try and disentangle some of the differences between virtual wards and hospital at home. Okay, so hospital at home. Now, this particular definition is from the UK Hospital at Home Society, and it took that particular NHS definition one step further. It describes this care model that provides, again, hospital-level care for acute conditions that would normally require an acute hospital bed delivered in a patient's home for a short episode through multidisciplinary healthcare teams. And when we start to think about hospital care at home, or hospital care in general, these models, they do vary in terms of what it can do, its level of intensity, based on how it's set up and the resources that's put into it. So it can deliver some hospital care at home, and some higher intensity model ones can deliver all forms of hospital care at home. They can range from something like a doctor's visit, a nurse's visit, some form of consultation conducted virtually, all the way to the administration of treatment in people's own homes, when that treatment consists of intravenous antibiotics, fluids, or any form of parenteral. But regardless of the shape, the size, how it's delivered, there are some common key features that underpin a hospital at home service. The first is there has to be some element of equity in terms of the illness that these patients have. Okay, there has to be some clear eligibility criteria for people to be included into these particular services. Built into hospital at home services, there has to be some expedited or urgent access to hospital level diagnostics and care. And this access could be into hospital, or it could be bringing hospital level diagnostics and care to people's own homes. So the role of point of care testing comes into the picture. Another key feature of this type of models is where there's daily input from hospital teams into patient care. And there's a clear recognition now that hospital at homes are specialist services, of which you need specialist teams with clear lines of leadership and responsibility, but also governance. And the last key feature for hospital at home services is it has to be multidisciplinary. Now, we've got this little picture here, which shows how hospital at homes function in terms of what it could potentially do. You have patients that present to emergency department, and hospital at home could provide an admission avoidance service, what most call a step-up model of care. So instead of patients from ED converting their ED stay into an inpatient care, a hospital at home service could potentially offer that avenue, that platform to manage their acute illness. The other way, another role that hospital at home could play is in terms of early supportive discharge, meaning that you've got patients who are already in hospital in an inpatient bed. And the question is, if they still required some inpatient element, could this inpatient element then be delivered in your own home? A step-down model of care. But here's a slide on perhaps what it isn't. At the end of the day, hospital at home is not a safety net for people that you are going to discharge from hospital, meaning that, right, the illness, the recovery is now complete, but just in case, here is a service for you to provide that safety net. And that's not really what hospital at homes have been set up to be. It's not an outpatient service. It's not a community service, and it's not catered for chronic disease management. And it certainly isn't to look after patients who are critically ill with highly complex management goals. So does it work? Thankfully, there is a wealth of literature that has certainly supported the effectiveness and the clinical impact that hospital at home services can deliver. So I've just basically plucked this umbrella review, which is a systematic review of systematic reviews, which very much emphasizes that used appropriately, used well, delivered efficiently, hospital at home, whether a combination of early supportive discharge or admission avoidance model, can make a difference when we talk about mortality, readmission, healthcare resource use, and readmissions. Now, if you're watching this on a recorded platform, you can press pause at this stage. But what I've just done here is highlighted a couple of systematic reviews that contributed to that particular umbrella review, but also studies that were published subsequently. And what it does tend to show is a very consistent message with regards to what hospital at homes could deliver. At the end of the day, mortality compared to usual routine inpatient care is similar, if not better. Patients cared for within these types of services are more likely to remain at home. There is a less risk of institutionalization. They have potentially shorter length of stay. But here is the key one here, because most people would shirk at the idea of, gosh, looking after someone who's not well, that we would traditionally look after in hospital, as a very risky endeavor. The published literature today has certainly not reported any increase in adverse events. And again, mortality, if we look at that particular outcome, hasn't shown to be worse for patients who are looked after within these types of models. But what hospital at homes and even virtual wards can potentially deliver is the opportunity to create capacity without physically building new wards, building new hospitals. Now, so I get asked quite often, do patients want something like this? Are they willing to accept something like this? There are studies that's been published on this. I've just plucked this one because it was conducted by one of our collaborators in Singapore. So NUHS, when they were embarking on their own hospital at home journey, they did a survey, very simple survey. They asked patients, they asked caregivers of patients, if we had something like a hospital at home for your particular healthcare problem, is this something that you would accept? And the majority of people, and you can see the sort of the green shade on this particular table, most would say yes, whether that's definitely or potentially yes, but the majority would be, yep, I think it's something that I would consider and I would potentially accept. So colleagues in Singapore did embark on their hospital at home journey, and they published their experience from, how it went after a year of initiation of the hospital home service. And the reason why I wanted to highlight this was because we are starting to see some parallels with our own journey with what they went through. So they started their service back in September 2020. COVID was one of the drivers behind their particular drive to do hospital at home. They screened, over 16,000 patients. They identified, just over 300 people that were eligible, of which 100 people were admitted. And talking to them, it was a challenging journey when they started off. Most of the patients were grouped under that early supportive discharge category, and only a quarter of them being admission avoidance. What sort of patients they look after? Most had an infection element. So they talked about skin infection, UTI, and fluid overload. So that's your very brief experience first year on this particular journey. But when we look at how services, hospital home services have matured in other parts of the world, including in Singapore, once it gets going, once the initial challenges were not to say completely addressed, but once momentum started growing with these sort of services, acceptance grew, expansion happened, and it became very much running in parallel with usual hospital care. Some snippets from the press, from the NHS, but also from this particular one from the Straits Times, talking about the expansion of their hospital at home service. And for us locally, the idea of looking after people at home isn't exactly new or foreign. I mean, we were doing it during the time of COVID. This was Cosmos, where we were able to monitor low-risk patients with COVID in their own home, utilizing remote monitoring, Telegram, and so forth. So not exactly new, not exactly foreign, certainly to our institution. So I wanted to maybe spend just one slide and try to explain that there are certainly differences. So as people are doing more of this, people are embarking on their own individual hospital home journey, it became very clear that there was a need to define what exactly a hospital at home is and what exactly is a virtual ward services, so that when people go around and talk about hospital at home, everyone more or less can understand what it is the service alludes to. But the key difference with regards to hospital at home and virtual ward is that hospital at home provides a physical hospital at home service, where you have face-to-face care at home through a multidisciplinary team into the community, a true alternative to hospital inpatient care. Virtual wards, on the other hand, is the adoption of technology to provide care outside the hospital, not necessarily delivering a face-to-face care in the community itself. Most hospital home services, certainly most of the ones in England that's funded by the NHS, have a combination of a virtual ward element embedded into their hospital at home service. But what you will see subsequently from my side is that what we are perhaps embarking on at this stage of our PPM journey isn't a true hospital home service, but one that is a virtual ward. So on that note, let's come and talk about our journey so far. So what were the drivers? What made us decide, you know what, let's try and do this? You've heard already one particular reason from Professor Chin in the introduction, was at the end of the day, the hospital functions on a finite amount of resources, and that resource isn't able to keep up with demands. You've got two figures there which report the biggest demographic of hospital utilization. So in PPM's hospital utilization are the ones that we look after in the geriatric medicine unit. And we know that continuing as we are doesn't make sense, and we needed to really explore different models of care, different ways of delivering care. On the other side, we also felt that patients should always have a choice. We should always, if we can, provide the option for older people to be looked after in their preferred place. And that preferred place could be home, could be their home. And if we are able to do it, that is something that we believe we should offer. And the last driver for why we embarked on this journey was certainly there is a local wider telemedicine agenda. So all the stars aligned and off we went. So briefly, just the timeline of where we started and where we are today. This is me sort of summarizing key time points. So a chance attendance at a mesyuarat pengurusan led to the formation of our Jawatan Kuasa Gerak Kerja to establish this virtual hospital service. And that meeting took place just about a year ago, 21st of February. And not long after that, like most things, it's officiated by the formation of a WhatsApp group. So our Geriatric virtual WhatsApp group was formed back in March. We then identified a space within Ward 13U, and you can see what the space looked like in the beginning, what it looked like now that we've been using it for the last few weeks. It's a lot more messy, but we do have a room. We do have a signpost, a signboard that's stuck onto the door, which acknowledged the running of the service. A few months later, we had the delivery of our first set of hardware, for which we are grateful for, computers, laptops, and also I must acknowledge that the delivery of furniture as well, because you can't have an office without furniture. And those little things like that very much highlighted the commitment the hospital had to driving this particular agenda. We had a couple of very engaging meetings, and the first one was with colleagues in Singapore. So Singapore's hospital at home service is called Mobile Inpatient Care at Home, delivered under the purview of the Ministry of Health. So we had a really engaging online meeting with the team there about their own journey, learning from what they went through, and how we can maybe use some of those experiences in our own experience. We had a meeting with actually a few healthcare tech providers locally. This was one with QMed Asia that again eventually became one of the partners in our virtual ward journey. Lots of meeting took place over the last 12 months. There is an acknowledgement slide at the back, and it highlights every single department that we spoke to. Here in the picture, you can see us going to primary care, pathology, rehab medicine, ED. Planning, talking, led to an application to the Jawatan Kuasa Penasihat Perubatan, the MHC, and we got the green light to go ahead with running the service as a pilot in November last year. Between starting and this particular approval, it was sandwiched with a visit to see what happens across the causeway in Singapore, how they run their models, how their models have grown, and what they found potentially worked. Early this month, we had the delivery from QMed Asia for our remote monitoring equipment. And we officially started our pilot virtual ward on the 9th of January 2024. And these are some pictures of the first person that we recruited into our service on that particular day. Now, so I'm just conscious of time, so I'm just going to briefly move through this because I would like to see some of the questions that you would have about our service. But our virtual ward is a hospital-centric care, so we are not able to reach out into the community just yet. But what we try to do to address this particular limitation is to deliver our service using a combination of remote monitoring, virtual consultation, and a caregiver-directed treatment, meaning the caregiver of these patients become some of the care providers that we would normally do in hospital. We created expedited access to hospital-level care, meaning if there are any diagnostics or treatment requirements that we can only deliver in hospital, we make sure that we have a pathway to get them back in as soon as possible. So let me go through just very briefly how we have operationalized our service. It starts by a period of screening in ED, screening on certain wards that we know would perhaps provide us with suitable patients. Once eligibility is determined, we explore the patients and the family's willingness to participate. And if they say, yep, it's something that we're willing to consider, we take consent and we moved on to training. We tell them in more detail what the service entails, what happens when you're in the service, what you need to do with the remote monitoring equipment. And that's a picture at the bottom right-hand corner of what our kit looks like. And they look very familiar to many people. And we were conscious that whichever kit that we were going with had to be something that our group of patients is comfortable using. There is a blood pressure monitor, a saturation monitor, a glucometer, thermometer, all within the kit. And what's the beauty of the kit is it's Bluetooth connected to a gateway. Data is uploaded to the cloud and we download it and it presents itself onto a dashboard. So we can certainly remotely monitor patients as part of this service. We inform our patients about the communication channel. We tell them also that every time you send us a message, there is always going to be a nurse who will be acknowledging that message and making sure that it's acted on to create that level of confidence in the safety of the service. And we have clear escalation plans, which we will tell these patients about. Once they're in, we see them virtually every day. And this is a good-looking bloke doing a virtual consultation with this particular individual. And this is just a snapshot of what our remote monitoring dashboard looks like. Patients do this with the support of their caregiver. Automated information, we see it, and we respond to it. Okay, so I'm going to quickly end by just sharing some case examples of people that we have recruited, just to give you a picture of what this service could do. So we saw an 80-year-old lady who presented with fever and breathlessness. She was diagnosed with pneumonia and in the emergency department was started on intravenous treatment. She didn't require oxygen. She had diabetes and hypertension as a consequence of her not feeling very well for the preceding 1 week. Her sugars were not very stable. Her blood pressure was on the low side. And prior to her being poorly, she was an independent person who lived with her family. So where did we come in? We, on screening, picked her up. She was risk stratified and was deemed to be a low severity pneumonia, which meant that she could be safely managed with oral antibiotics. She did improve in terms of oral antibiotic and she no longer required intravenous fluids. But her sugars and her blood pressure still needed some element of monitoring. And we know that on the basis of the antibiotic requirement that's been stepped down, the medicines that need to be titrated, she would be someone that we would have kept in hospital, certainly for a few days, to make sure that's okay before we discharge her. But hey, we've got a virtual ward. We spoke to the team, we spoke to her and the family of this particular patient, and we decided, you know what, we could safely manage this. And we did. She did have to return to hospital for a one-off blood test, which they were happy to do. She's been discharged after spending 3 days within the virtual ward service. Another example was someone who presented with non-infectious gastroenteritis, which led to electrolyte abnormalities. And again, the diarrhea led to instability of his normally very well controlled comorbidities, and he lived in a nursing home. And he was kept in to make sure that his electrolytes were normalized. His sugars, because this man was on insulin, was normal before he would have gone home. And we said to the team, could this be someone that we manage? They said yes. And we recruited. We monitored him through the virtual ward with his carer assistants, titrated his medicines, and again, safely discharged a few days later. So moving forward, we want to grow, we want to sustain it, and we want to make us better at what we do. And this is my last slide. And this is something that I pinch unashamedly from colleagues in Singapore. And because I thought it resonated with what we really wanted to do, which was any patient that wants to be at home and can be at home should be at home. So I want to acknowledge everybody that's been a part of this journey, every single jabatan and department within the hospital who helped us set this service up to this very point, and the grant assistants and also colleagues with our names and details there if you want further information. Okay, thank you very much. Oh, sorry, I think they're gonna.
We have a few questions from the audience. We have one from Professor Gina. Sorry to ask my questions. How do you find carers' acceptance and confidence using the home monitors?
Good question. So the confidence and the unfamiliarity of the service and the tech and the virtual ward requirements is at the moment the biggest reason someone says no to us. So of the people that were deemed eligible, we are only recruiting about 1 in 3, 1 in 4. And the biggest reason is we're not quite sure about the tech part of it. So it does take a while for us to talk them through and reassure them. But that's something that we acknowledge to be something that it is. But I like to think with time, we would be a bit better at conveying some of these challenges to make them at least a little more confident in the service that we want to provide.
I hope that answers your question. Prof. Tunku Sara has, thank you very much for saying well done, and saying that this was an up-to-date move. As such, Tunku Sara wants to find out with regards to the cost for virtual ward and also the hospital at home versus hospitalization.
Okay, so good question. The cost, is it more expensive? The answer is no. We have done our preliminary micro-costing exercise prior to the start, based on what we think the hospitals, the virtual ward service will require. So it is cheaper than an inpatient stay. That's the first thing to say. But alongside what we are doing, and I want to acknowledge Prof. Masna at this point, who will be helping us with some cost analysis of the service to refine our costing exercise. But looking at what we have put so far, it will still be cheaper than someone having to come into hospital.
A further question, do the caregivers go on call to help provide access to 24-hour care? And I know that UMMC does not charge exorbitantly, but what would be the appropriate fees compared to normal staying fees? I think that's partially been answered as such.
But the caregiver part is, so part of the consent and the training, we always establish from a caregiver perspective, how involved are you with your patient, with the person's care? And we do expect, if possible, care to be delivered 24/7. Because remember, these are patients that would normally be in hospital, requiring some level of observation and monitoring. So we do engage care and say, you know what, if you go down this route, we hope that you can support the safety of this service by being there, 24/7, if need be. If anything happens at 2 a.m, at least you're there to highlight the issue, certainly to us for further management. So yeah, there is that requirement.
And one last question is about indemnity cover for healthcare professionals.
That's a really good question, and this is one that has vexed us for a bit. Certainly locally, what we're embarking on is an entirely new thing. We've had a number of discussions with our legal team about this, indemnity for healthcare professionals, but also indemnity for the hospital, because we are looking after patients outside the physical building of the hospital. Does that cover? At the moment, what we do is covered. I think our local indemnity provider is watching this space very carefully, but as it stands, the short answer is yes, it is still being covered at the moment.
Thank you very much, Dr. Terence. I think we are a little bit over time, so I'll pass this to Dr. Chong Lee Ai.